The following podcast is part of a certified educational activity titled At the Ready for a New Standard of Alzheimer's Care, Preparing Your Practice for the New Era of Amyloid-Targeting Therapies. Access the entire activity and complete the post-test at peerview.com/GBW860. Downloadable slides and practice aids are also available.
Hi, I'm David Walk. I'm a professor of neurology and director of our Penn Alzheimer's Disease Research Center and co-director of the Penn Memory Center at the University of Pennsylvania. And we think we have a really unique activity today exploring the latest evidence supporting new treatments for Alzheimer's disease. And so to start, why don't we tell you about what the goals are of the talk today. So what we'd like to do is really enhance your understanding of the mechanism of action and latest evidence supporting the use of these new anti-amyloid targeting therapies for the management of early symptomatic Alzheimer's disease. We want to increase your ability to identify patients with early symptomatic Alzheimer's disease for whom anti-amyloid therapy would be most appropriate. And we want to augment your skills needed to really involve patients as a part of shared decision-making and educating them with regard to the risks, benefits, and goals of treatment of these anti-amyloid therapy treatments. So how do these new anti-amyloid therapies work? Well, the ones that have been approved and the ones that have been most well studied in the field are immunoglobulins that bind to various forms of amyloid in the brain, amyloid plaques and other species of amyloid. When these antibodies bind to amyloid, they trigger a reaction or activation of microglia that then phagocytize the amyloid and help effectively clear the plaques from the brain. So just to remind you, what is amyloid? The amyloid that we talk about with Alzheimer's disease? Well, it's made up of the A-beta protein, which is a fragment of the amyloid precursor protein, which is cleaved by two enzymes, the gamma and beta secretase. And it then kind of aggregates together to form from monomers to oligomers to fibrils, and then eventually into plaques. And it turns out that a number of the different antibodies that have been studied to remove amyloid from the brain target different species of this pathway of amyloid aggregation. So for example, there was one drug that had been studied in the past called solanezumab, which bound to amyloid oligomers, or monomers, which are single molecules of A-beta. Whereas the first approved drug for Alzheimer's, aducanumab, which underwent accelerated approval by the FDA, had a preference for binding to fibrils. Lecanemab, the first fully approved drug for Alzheimer's disease of this form, binds preferentially to protofibrils, although also binds to some extent to other forms of amyloid as well. Whereas donanemab, the most recently approved drug, is quite specific for the amyloid plaques of Alzheimer's disease. And so what do these drugs do when you give them to patients? Well, they have been shown, particularly the approved ones, to really substantially reduce the load of amyloid plaques in the brain, usually measured by amyloid PET, within about a 12 to 18 month period. What's I think really interesting and important about these drugs is that amyloid is thought to be the beginning of a cascade in which it promotes tau and tangle formation, neurodegeneration, inflammation. And I think encouragingly, these drugs also seem to move biomarkers that are associated with those downstream effects as well. Although with neurodegeneration, there was some mixed data. In terms of its effect on cognition, these drugs seem to slow down the course of the disease by about 25 to 35%. And so if you think about an 18-month period, they basically give back 5 or 7 months of expected decline over that period of time. So why don't we look at the data? This is from the Clarity AD study, which was the definitive phase 3 trial studying lecanemab. This figure here shows you on the y-axis the degree of reduction in amyloid measured by a metric called centiloids. So the more negative this goes, the more change or reduction in amyloid there was in the brain. And you can see there was a really robust effect, even at 3 months, where lecanemab had a significant reduction in the amount of amyloid in the brain relative to placebo. And this amount of about 60 centiloids essentially takes many patients from being amyloid positive to amyloid negative over that time period. Well, that's great that we see this effect on amyloid PET and on amyloid in general, but really what's important is how does this impact the cognition and function of our patients? And this was the primary outcome measure of that from the Clarity AD study, looking at a measure called the Clinical Dementia Rating Scale, Sum of Boxes, which is a measure of both cognition and function. And what can be seen here is the lecanemab group had less of a change or reduction in this measure, or increase in this measure, because the higher it goes, the worse you're doing, relative to the placebo group, such that by the end of 18 months, there was about a 27% slowing on the lecanemab treatment relative to the placebo arm. In many ways, this drug was very well tolerated. If you look at things like death, there was a similar rate in both the placebo and the lecanemab arm. There was a slightly higher rate of serious adverse events. But the big side effect that we do worry about with these drugs is something called amyloid-related imaging abnormalities, or ARIA, which can either be edema, E, or microhemorrhage, H. And about 15-20% of individuals total had either ARIA-E or ARIA-H as a side effect of lecanemab. Now, in the vast majority of cases, more than 75%, it was asymptomatic, and in those 25% that it was symptomatic, many it was reversible. But there are a significant proportion of people, about 1%, that can have a more serious neurologic event as a result. And so this is something you have to monitor closely. Another really common side effect of the drug was infusion reactions, which occurred in about a quarter of these patients, although usually these were very self-limited and only occurred on the initial infusions. Well, how about donanemab, the other approved drug? Well, this is data from its phase 3 study called TRAILBLAZER-ALZ 2. And again, just like with lecanemab, although perhaps a little bit more robustly, there was a really significant reduction in amyloid plaques in the brain based on PET imaging compared to the placebo group. So by the end of the trial, about 76% clearance of their initial level of amyloid was found, of which many of those patients, again, achieved a level of being amyloid negative by the end of the study. Just like lecanemab, similar benefits on the Clinical Dementia Rating Scale, Sum of Boxes, were seen with a decreased or decreased rate of decline with donanemab relative to placebo. In this case, about a 29% slowing with this particular scale. Side effect profiles were very similar with donanemab as they were with lecanemab. There was a somewhat higher rate of ARIA-E and H in this population, although this population was a little bit more impaired than the population in the lecanemab study. There actually were less in the way of infusion-related reactions with donanemab than with lecanemab.
Hi, my name is Gil Rabinovich. I'm a professor of neurology and radiology at the University of California, San Francisco, and the director of the UCSF Alzheimer's Disease Research Center. And it's really a pleasure to be part of this program. So in this chapter, I'm going to cover differences between the two approved amyloid-targeting therapies in terms of dosing, administration, and potential for limited duration dosing. This table shows differences between the clinical trial design and dosing schedules, MRI monitoring schedules for donanemab from the TRAILBLAZER-ALZ 2 clinical trial in the left column, and lecanemab, the Clarity AD trial, in the right column. You can see that donanemab is dosed every 4 weeks, lecanemab every 2 weeks. There are differences in infusion time. Donanemab does have a dose titration where the dose is 700 milligrams for the first 3 infusions and then increased to 1400 milligrams thereafter, whereas there's no dose titration for lecanemab with the dosing based on weight at 10 milligrams per kilogram. The design of the clinical trials was different. So in the TRAILBLAZER-ALZ 2 donanemab trial, patients were actually switched to placebo if they had met criteria for clearing amyloid plaques based on PET at 6, 12, or 18 months. And so there was a limited duration dosing built into that trial design. In lecanemab, patients received either drug or placebo throughout the trial, and so we don't actually know if there's a potential for limited duration of treatment. And the MRI monitoring schedules are a little bit different. For donanemab, we recommend safety MRIs prior to the 2nd, 3rd, 4th, and 7th dose, whereas the schedule for lecanemab is prior to the 5th, 7th, and 14th dose, respectively. This is a table that shows the percent of patients in the trial on active treatment that had actually cleared plaques at different trial time points. And so you can see that patients, 17% of patients met the criteria for moving to placebo based on PET at week 24, 46.6% at week 52, and 69.2% by week 76. So the majority of patients actually did not require treatment for the full duration, 76 weeks of the trial. Another criteria that we use for clearing amyloid on PET is a quantitative threshold of 24 centiloids. And there was a little bit higher proportion of patients at each of the time points that met those criteria. Now, in the trial, the criteria for plaque clearance was based on a quantitative threshold using the centiloid measure, which is a standardized measure for quantifying amyloid PET results. In clinical practice, according to the prescribing information, the dosing would be stopped based on reduction of amyloid plaques to minimal levels based on a visual read, which is currently the FDA-approved method for interpreting amyloid PET scans. So a little bit of a difference between how the trial was conducted and how PET clearance might actually work in clinical practice. This graph demonstrates the difference between drug and placebo only in the subset of patients who ultimately were switched to placebo at some point during the trial duration. And you can see that there is a significant difference at different time points, including at the 76-week time point, between patients receiving drug and placebo, even though the drug was stopped early, on average after 47 weeks in these individuals. And so this is the kind of evidence that demonstrates that there is efficacy of donanemab even when you only treat patients for a limited duration of time, titrating that duration based on their PET response. There are many ongoing unanswered questions that need to be explored regarding these amyloid-targeting therapies. Are the treatment effects in patients with typical Alzheimer's disease based on the inclusion criteria in the trial generalizable to broader populations? We will discuss more in detail that racial and ethnic minoritized groups were underrepresented in these trials, so generalization to those populations still needs to be demonstrated. And additionally, patients in real clinical practice tend to be, in general, sicker and have more medical comorbidities than those in clinical trials. Now, while the clinical trials for lecanemab and donanemab treated symptomatic patients at the early clinical stage of disease, there are ongoing clinical trials with both agents treating people who are cognitively unimpaired but have Alzheimer's disease pathology based on positive biomarkers. And a critical question in the field is whether treatment with these monoclonal antibodies might slow or even prevent cognitive decline in these individuals who currently have preclinical Alzheimer's disease. So stay tuned for results for those trials. It's going to be very important as these drugs are rolled out in clinical practice to continue to monitor their efficacy and safety in real-world practice. The Centers for Medicare and Medicaid Service have opened a registry. In order to enable Medicare coverage for these drugs, patients must be enrolled in a CMS-approved registry. either the registry that Medicare itself has put up or another CMS-approved registry that I would encourage all of you to consider is the Alzheimer's Network, or ALZ-NET, which is hosted by the Alzheimer's Association. The second registry includes much more detailed clinical information, banking of potentially biosamples, imaging studies, and additional clinical data. So these registries will really help inform the efficacy and safety of these drugs as they're rolled out into real-world clinical practice.
All right, well, so how do we work up patients for Alzheimer's disease, particularly when we're thinking about potentially applying these new amyloid-targeting therapies? Well, there's kind of a typical stream of how we would evaluate patients. And to some extent, some aspects of this stream can really be well managed by primary care physicians. And then at later stages, it's often helpful to refer patients to a memory clinic that is specialized in this area. Initially, just like any aspect of medicine, really a key is to obtain a good history from the patient and family about their medical status. You're going to want to do a neurologic and physical exam. Often you'll end up sending some degree of blood tests for potential reversible causes of cognitive impairment. It's important to do some sort of cognitive and functional assessment. And then in everyone that we work up for the possibility of Alzheimer's disease, we'll obtain structural imaging, usually with MRI. And then to better determine what the underlying pathology is, that's when we'll generally get to the point of using biomarkers. So to kind of unpack that a little bit more, one thing I think that's just important to keep in mind is the only way you're going to diagnose Alzheimer's disease, particularly at early stages, is to look for it. And so we can't dismiss the kind of typical mild memory complaints that we hear from older adults as just being normal aging. We have to really take those complaints seriously and try to better understand them. The assessments of these patients are, again, going to include a history of the patient as well as their family history. One of the really important things when you're evaluating patients with cognitive disorders is that these visits really require both the patient and also someone who knows the patient well, who can give their perspective, which we refer to as a care partner. It's usually a spouse or a child. And this is important for a number of reasons, including the fact that patients sometimes have less insight into their problem than a care partner might. Again, you want to know about medical history, disease history, particularly psychiatric symptoms that can affect cognition, like depression. Medications are needed to be reviewed for those medications that can affect cognition. You want to know about lifestyle factors, risk factors for cognitive impairment, like smoking, excessive alcohol use, and exercise, which actually is a benefit to reducing your risk of the disease. Again, at some point, lab tests will be sent for so-called reversible causes of cognitive impairment, like B12 and thyroid. And then you do a general physical exam. The neurological exam is something that we really do in large part to rule out non-Alzheimer's disease pathologies. So if you see Parkinsonism or other kinds of motor features that would suggest us against Alzheimer's disease, we really expect a normal neurological exam in Alzheimer's cases. Then one should go and do some sort of cognitive assessment. And again, I think in really any practice, it's important to at least do a screening measure of cognition. And the most commonly used ones are the mini mental status examination and the MoCA. It's important to get some assessment of function, the ability to do instrumental activities of daily living, which include things like the checkbook, driving, managing your medicines, as well as more basic activities of daily living like hygiene, dressing, etc. And there are a number of scales that do that. If you're worried about psychiatric symptoms, measures of anxiety and mood can be helpful, like the geriatric depression scale. And then, finally, we're going to get some imaging. And as I mentioned, often we get MRI scans, and in large part, we're getting that both to look for signs on the MRI that are suggestive of Alzheimer's, but also to rule out other potential contributors. Well, when we think about the staging of Alzheimer's disease, there has historically been a number of different staging systems out there. This is a relatively new one that came out as part of new diagnostic criteria for Alzheimer's disease, which breaks down the disease into 6 stages and really reflects the idea that Alzheimer's disease is a continuum. Stage 1 is actually a preclinical stage when patients are asymptomatic but have evidence of Alzheimer's pathology. Stage 2 reflects kind of where there's just very minimal evidence of some degree of cognitive decline. Stage 3 is what we would often call mild cognitive impairment, which is when patients have objective evidence of memory and thinking impairment, but not enough to really cause incapacity in function, whereas by definition, dementia is associated with loss of independence on different skills. And mild dementia, stage 4, is when people have difficulty with some of their instrumental activities of daily living that they need help with, for example, the checkbook, but they're still able to do most of their basic activities of daily living. And it's worth pointing out that stage 3 and stage 4 are the target stages in the trials and what we're targeting with these amyloid-targeting therapeutics. And just to give you some sense of the ballpark scores that you'll see at stage 3 and 4, the MoCA is about 18 to 25, and the mini-mental is typically around 20 to 30. What's the role of MRI and workup of MCI and Alzheimer's disease? Again, mild cognitive impairment allows us to rule out other conditions like tumors and strokes. It also, though, has features that sometimes help us get closer to a diagnosis of Alzheimer's disease. So things that are suggestive are hippocampal atrophy, for example. Importantly, it also gives us information about the likelihood of amyloid angiopathy, which may play a role in whether or not one of these anti-amyloid therapies is safe. And when we are working patients up for their eligibility, we actually obtain a number of sequences, but in particular, a GRE, a gradient echo, or susceptibility weighted imaging is important to look for these microhemorrhages. What about molecularly specific markers of Alzheimer's disease? Those are necessary to then apply the anti-amyloid therapy. And they're recently defined, quote unquote, core 1 biomarkers of Alzheimer's disease. These are either imaging markers, amyloid PET, or cerebrospinal fluid markers that have high likelihood of being associated with underlying Alzheimer's pathology. As many of you may know, there are these newer plasma markers out there. Right now, I wouldn't advocate for using these in our practice for determination of anti-amyloid drugs, but I think they will become more and more integrated into our practice in the future. There are advantages and disadvantages to each of these. For plasma, it's obviously the big advantage is the ease of obtaining that information. It's just a blood draw. PET is somewhat less invasive than spinal fluid studies and was actually used as an outcome measure in the clinical trials I mentioned earlier. CSF has a very long history in terms of its validity relative to pathology as well. I'm not going to go through all these, but there are actually a number of choices with amyloid PET tracers. They're all pretty equivalent to each other. There's one tau PET approved tracer and 2 FDA approved CSF measures, and then multiple and growing plasma measures that are used. In terms of thinking of who we should give these drugs to, there were inclusion and exclusion criteria that occurred in the phase 3 trials that helped guide what we think about this. And importantly, both studies focused on mild cognitive impairment or mild Alzheimer's disease. They both required evidence of amyloid in the brain. The donanemab study also required some evidence of tau pathology in the brain. And then in terms of exclusions, they tried to limit the number of people who had amyloid angiopathy, which seems to be related to ARIA, by not including people who had more than 4 microhemorrhages, or in the case of lecanemab, any area of what's called superficial siderosis, which is another area of bleeding, or donanemab allowed only one of those areas. Appropriate use criteria that have been published for lecanemab, not yet for donanemab, largely followed the inclusion-exclusion in those trials. Importantly, though, another area that these recommendations recommend against treating are patients who are on anticoagulants due to the bleeding risk associated with them.
So in this chapter, we'll be discussing safety considerations associated with amyloid-targeting therapies. The major side effect that we need to monitor is amyloid-related imaging abnormalities, or ARIA. ARIA are MRI changes that are related to fluid shifts as amyloid is cleared from the brain through blood vessels. And we think primarily occurs in blood vessels that have vascular amyloid deposits in them, that vessels that are affected by cerebral amyloid angiopathy, or CAA. ARIA comes in two flavors. ARIA can lead to edema or swelling in the brain. This is called ARIA-E. On the bottom row, you can see 4 examples of ARIA-E that can present with white matter hyperintensities or sulcal effusions, and you can see that these can range from subtle and mild, as shown in case 1, to quite severe, as shown in case 2, for example. ARIA also can cause hemorrhage, typically microhemorrhages or superficial siderosis, rarely macrohemorrhages or intracranial hemorrhages. And you can see examples of ARIA-H as detected by hemosiderin MRI sequences on the bottom 2 panels in the bottom row. Now, ARIA is typically asymptomatic and is detected through MRI surveillance. ARIA-E in particular resolves spontaneously. When patients do have symptoms, they typically are mild, nonspecific, like headache, dizziness, increased confusion, but they can be serious and occasionally life-threatening. There have been a handful of cases of patients who have died due to severe ARIA. And so this is a significant potential adverse event that needs to be taken very seriously and monitored for very carefully. The primary risk factors for ARIA are the number of APOE4 alleles the patient has. Lowest risk for ARIA is patients who do not carry a copy of APOE4, highest risk in E4 homozygotes, and intermediate risk in E4 heterozygotes. ARIA is also associated with the dose and timing of the treatment, so it's more common with higher doses earlier in the treatment course. The presence of underlying CAA is a significant risk factor for ARIA. We detect that by pre-treatment MRI scans that look for microbleeds or evidence of siderosis, and patients who have extensive ischemic vascular changes on MRI may also be at higher risk for ARIA. Because ARIA risk is so strongly associated with APOE genotyping, the recommendation is to genotype individuals who are being considered for amyloid-targeting therapies in order to understand their risk. Carrying APOE4 in a dose-dependent manner is associated not only with a higher incidence of ARIA, but also with earlier occurrence, a higher chance of recurrent, and a higher chance of severe ARIA. And so really an informed discussion about risks and benefits for patients requires this information about APOE genotype in order to truly inform patients and their families about the risks and the potential for ARIA. These graphs demonstrate the rates of ARIA-E in the Clarity AD phase 3 trial of lecanemab. On the left, you can see the overall occurrence of ARIA. So you can see that ARIA typically occurred very early in the course of disease overall. And on the right panel, you can see the rates of ARIA now stratified by APOE4 genotype. And so you can see significantly higher rates of ARIA-E in E4 homozygotes shown in blue compared to heterozygotes in green, not E4 non-carriers in red, and all 3 of these groups had higher rates of ARIA-E than placebo. Similar graphs have been presented but are not yet published for donanemab, and those publications are anticipated very soon. ARIA-E in particular shares some characteristics with another spontaneous disease entity unrelated to treatment called cerebral amyloid angiopathy-related inflammation, or CAA-ri. Again, this occurs spontaneously, rarely in individuals. and shares the same risk factors as iatrogenic ARIA. So number of microbleeds at baseline MRI, APOE4 genotype. ARIA and CAA-ri tend to occur in locations where CAA is known to occur in the brain in cortical areas and leptomeninges. And now that we are starting to have some animal models of ARIA, we can see that there's a very common pathophysiology, including infiltration of inflammatory cells and other elements that are just very similar. So we think that ARIA is really a treatment-related form of CAA-ri, and the treatment is accordingly recommended. Another important potential adverse effects of amyloid-targeting therapies are infusion reactions. These typically occur during the first few infusions. They're very often mild to moderate in severity, and they typically resolve within 24 hours and can almost always be managed as an outpatient. The symptoms are similar to other infusion reactions associated with other biologic agents, fevers, chills, headaches, etc. But occasionally severe reactions, including anaphylaxis, are possible. And so clinics that are providing these infusions need to be prepared with bronchodilators, oxygen, and epinephrine in case someone has an anaphylactic type reaction to the infusion. When we discuss amyloid-targeting therapies, it's important to note that there are racial and ethnic disparities in the prevalence of Alzheimer's disease and in participation in clinical trials. Published studies suggest that older Black, Latino, and Hispanic Americans have a higher risk for developing dementia during their lifetime than older non-Hispanic white Americans. Yet despite having a higher risk for disease, the literature suggests that these individuals might encounter barriers to care, and in particular to an early diagnosis at the mild stage of disease and to the comprehensive evaluation that leads to a precise diagnosis and potentially to specific therapies. It's also very important to be transparent with patients that all the underserved groups noted in this third bullet, Black, Latino, Hispanic, Asian Americans, and Pacific Islanders, as well as American Indians and Alaska Natives, were really underrepresented in the clinical trials compared to the prevalence of the disease in these populations. And this limits the generalizability in our understanding of both safety and efficacy in these different populations. As sites prepare to administer amyloid-targeting therapies, it's important to be very proactive in identifying and addressing any barriers to implementation, and these will vary depending on your clinic and institution. In order to identify candidates for therapies, sites have to have biomarker testing capabilities, either for PET scanning or CSF biomarker testing. It's very important to be proactive about patient safety and ensure that patients have access to APOE genotyping and genetic counseling if required prior to and after receiving their APOE results. It's going to be very important for the clinics to work closely with emergency physicians and primary care providers, specifically around this issue of ARIA and identifying appropriate signs and symptoms. And then from a patient perspective, it's going to be important for clinics to work closely with patients to identify any potential financial barriers, including costs and copays of the treatment themselves or the diagnostic procedures, as well as any barriers to insurance reimbursement. And as we'll show on a subsequent slide, the pharmaceutical companies do have patient support services to help practices and patients navigate through some of these potential barriers. In this chapter, we'll be discussing shared clinical decision-making and patient education as they pertain to amyloid-targeting therapies. So what is shared decision-making? Shared decision-making is really a process through which, through conversations between the patient, their care partners, and the healthcare team, we reach a shared agreement about the patient's values and the decision about whether to undergo therapy. This is a collaborative process that really emphasize the autonomy of patients to make informed decisions for themselves. And the role of the healthcare provider is to provide the support, education, and information that patients and families need in order to make these autonomous decisions. Often our role as healthcare providers is to review the risks and benefits of the different treatment options, including amyloid-targeting therapies, to share information about these options, answer any questions that patients and families may have, and ultimately ensure that everyone reaches a decision that best reflects the interests and values of the patient. When having these conversations, it's important for the healthcare provider to help identify the patient's goals, their values, their preferences, to support their active participation in the decision-making process along with their care partner and family, and also to establish realistic expectations, both around efficacy and safety of this class of drugs. There can be occasional barriers to this process of shared decision-making. From the provider perspective, providers may feel like they lack expertise in moderating these types of conversations, and they may feel like they don't have all the information they need in order to address the patient and family's concerns. From a patient point of view, they will likely require support. The risks and benefits of this class of therapy is fairly nuanced, and so one would expect that patients and family would have questions, may need to repeat questions in order to fully process the information. There can often be multiple family members involved in supporting the patient and making the decision, and patients themselves may have difficulty remembering what was discussed. And so it's very important, in addition to the discussion itself, to provide patients and families with different visual aids or other media, including printed materials or video links, an opportunity basically to review some of the information that was shared at home and as they consider their decision. There are several elements that should be considered in the discussions as patients are making decisions about whether they're interested in ATTs. One is the expected benefit. These drugs don't improve memory, they don't stop memory decline, but they do slow cognitive and functional decline. And so it's important for patients and families to have realistic expectations about how success is measured and what effectiveness truly means. We covered the risks and symptoms of ARIA that are important to watch out for. Very important to cover ARIA in detail as you go through the potential risks of treatment. Patients and families need to understand the commitment that they're committing to in terms of receiving these therapies, including the frequent infusions, the need for PET or CSF testing for biomarkers, the multiple MRIs that are needed to monitor for ARIA. It's going to be important to have expectations about what the treatment will cost and whether it will be covered by insurance. And we have to acknowledge that this is a very new class of therapies, and there's still a lot of questions that are unanswered based on the clinical trial data. We don't really know about safety and efficacy in patients beyond those that were included in the trials, so those who are younger or older or have more comorbidities. As we covered earlier, we have questions about the optimal duration of treatment and when the treatment should be stopped. And it's important to realize that there are other potential alternatives besides ATTs, including no treatment and including potentially participating in a clinical trial. And so, again, aligning the treatment plan with the patient's goals, values, and expectations is very important. This is an example of how to present information around ARIA as it relates to ATTs. It's important to use language that patients and families can understand. The visual aids that are demonstrated here can be very helpful for reminding patients about the types of symptoms they need to be concerned about, either frequently or less frequently with ARIA, the increased risk associated with APOE genotype. And so this is just an example of a visual aid that can be helpful for patients and families. It's very often helpful for patients to carry something on them, a band, a bracelet, or a card in their wallet that describes the therapy that they're getting and has contact information for the prescribing physician in case they do find themselves in the emergency room and need to communicate the special considerations that go into managing patients who are on ATTs. And the pharmaceutical companies do have patient assistant programs that can help patients, families, and clinical sites navigate some of the potential barriers of this new class of drugs. Here you see QR codes and website links for the specific patient support web resources for each of the 2 FDA-approved drugs. Another important aspect to consider is clinical meaningfulness. What kind of outcomes from treatment matter most to patients and care partners? The literature suggests that individuals who are experiencing early symptoms of Alzheimer's disease are most concerned about their memory or developing potential dependence. They desire improvement or restoration of memory. That would be ideal, but you can see that stopping or slowing progression of the disease is often also cited as a top desired outcome, as well as the ability to maintain function as much as possible and to perform activities of daily living. And patients often also talk about their need to maintain their emotional well-being, preserve their independence, and overall physical and mental health and safety beyond just Alzheimer's related outcomes. So how can the clinical trial data be translated into outcomes that are tangible for patients, like slowing a functional decline or stabilizing clinical symptoms? Let me give a couple of examples. One concept that can be helpful for patients is time saved. This refers to the concept that by receiving drug, they are actually slowing the course of the disease and gaining time in this relatively mild clinical stage of the disease. The graph below represents worsening on the y-axis in a clinical outcome measure, and you can see that patients who are receiving the drug are saving time in terms of where they are in their clinical stage compared to those receiving placebo. And so the typical magnitude of this effect is about 4 to 8 months, depending on the specific outcome that we're looking at in the phase 3 studies. So having those additional months in this early clinical phase can be a clinically meaningful outcome to help patients and families anchor their expectations. Another potential clinically meaningful milestone that I often use in my shared decision-making discussions with patients and families is progression to the next clinical stage of disease. That means that patients who start the treatment at the mild cognitive impairment phase may progress to a mild dementia phase, or patients who start with mild dementia may progress to moderate dementia. And these transitions are well captured in the Clinical Dementia Rating Global Scale, or CDR Global. These graphs show the risk of progressing on the CDR Global from MCI to mild dementia or from mild to moderate dementia for donanemab on the left and lecanemab on the right. And you can see that patients who are receiving drug have a lower risk, a hazard ratio of 0.61 for donanemab and about 0.69 for lecanemab. And so there is a lower likelihood of progressing to the next clinical stage. I frame this to patients, if they have MCI, for example, as, let's say, a 35 to 40% reduction in the likelihood that they will develop dependence in activities of daily living over the next year and a half. So again, I think a very meaningful clinical milestone to anchor your discussions with patients about potential benefits of treatment. So that concludes my part in this program. Thank you again for your attention, and really has been a pleasure to help present these materials to you. Thank you very much.
So I think, this is a wonderful time in our field. We now have these amyloid targeting therapies, but we do still need to think about the patients who don't qualify for these medicines, or patients who don't want to go on these medicines, which still makes up a large proportion of our clinical practices. And so what are some of the things we should do for those patients? Well, a lot of them are things that we should be doing in general for all of our patients, but we can provide additional support through social work, support groups. We can refer them and care partners for therapy if needed. We can establish home and community services like adult day programs for respite for the care partner. I'll spend a lot of time talking about the importance of lifestyle factors and how they benefit cognitive health. So things like a healthy diet, physical exercise, and social engagement. And generally, just maintaining good medical health seems to allow people to be more resilient to disease. We'll still give medicines that are for symptomatic treatment of Alzheimer's disease, so cholinesterase inhibitors, memantine, and we try to treat our behavioral or psychiatric symptoms appropriately as well. And importantly, in patients who don't qualify for lecanemab or donanemab, many of them do want to be aggressive about the disease, and so we try to refer them to clinical trials as well. And I think another question is, when do we stop these medicines due to progression? And there's no real right answer here. The drugs were designed and tested and shown to be of benefit in mild cognitive impairment and early, mild dementia cases. However, cases will progress to more moderate stages of disease. And I think at that point, it is worth a conversation with the patient and family that, one, we have less certainty as to how much the drug will be effective at that point. But two, do you want to continue with this high commitment, given the fact that the drug is only slowing things down at that point? And some families might say, at a more moderate stage of disease, maybe we don't want to further delay the course of the disease at that point with these medicines, especially given, again, the time and financial commitment. Obviously, in any older adult, there are challenges associated with pharmacologic management. And this obviously then applies to patients with Alzheimer's disease. And these include just considerations with any of the medicines you give about changes in pharmacokinetics and dynamics, as well as interaction with other medicines. I think one of the most important things to think about in our Alzheimer's disease patients is making sure that they're actually being monitored in their medicine taking and that they're taking their medicines correctly. And this often involves including the care partner. It's really important to include your patients in the decision-making process around these drugs and around any other aspects of treatment. And there's data to suggest that when patients don't feel like they're contributing, that all of your talking is directed at the care partner, that it has impacts on their quality of life and feeling of autonomy. How do you listen to patients with dementia? I think a lot of this is intuitive, but you really want to maintain eye contact. I've had patients where I've maybe focused a little too much on the care partner who've actually even commented on that to me. And so you really want to show that you're attentive to the patient, that you're listening, that you're giving nonverbal clues as to your understanding of what they're saying. And yet you don't interrupt them. You let them speak, even if they're sometimes struggling to get out what they want to say. You want to give them plenty of time. And when you communicate with them, again, a lot of this is intuitive, but you want to speak at a slow, clear pace. You want to give small bites of information to them so that they can kind of hold that more easily in their working memory. So that concludes our question-based assessment on the timely diagnosis and management of early Alzheimer's disease. Please review your learning plan summary before you leave, and I hope you found this activity informative and useful for your practice. Thank you very much.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Lilly. To access all materials for this activity, visit peerview.com/GBW860.